90% of prescriptions are handwritten, so you're still going to see that for quite a long time. What else?
Unnecessary drug therapy.
Unnecessary drug therapy. Yeah, so you guys, most of these things, you're working off what, your 7 drug-related problems. So again, all this stuff is tied in, and with some more clerical stuff like legible handwriting, SIG problems, and stuff like that. Okay. Now in the hospital, you'll also see. So I guess most of the time when I'm in here, we're talking about community pharmacy, but in the hospital and inpatient side of things, you'll see a lot of these same kind of issues too. So we're actually going to practice inpatient and then outpatient types of scenarios. All right, so why do you think we need to use SBAR? Well, first of all, what does SBAR stand for? Someone just raise your hand and just... Yes?
Situation, background, assessment, and
Okay, another person, what do those mean? Don't just give, well, she gave you the words, right? But in your own words, what does that mean to you? How would you describe SBAR? How to properly talk to a physician, okay. So situation, how do you describe situation?
What's going on?
The problem? Okay. What else? How do you describe background?
Relevant information.
patient background information, or like just kind of like what medication.
Okay, so background information, what's going on. Okay, what about assessment? Diagnosis, potentially, depends on how you word it, yeah. What else?
What led you to the problem?
Could be, yeah, what led to the problem, or some of that could be background too. Again, it depends on how you word it. Just think of the word assessment. What else? You guys did this already on paper. What do you think about it? Okay, so that's a good description. And the recommendation.
What are you going to do about it?
What do you suggest? Right? What do you want them to do? Right, so you don't have to think about SBAR, just simplify, right? What's going on, like who is the person you're talking about, right? What's some other background information? What's going on? What led up to that? What do you think about it? And what do you want someone to do, right? If that's helpful for you, use that method. But just like with SOAP notes, you're giving it all this information, your subjective, objective information, and your assessment, your plan. It's all very, very similar, right? And so why do we use SBAR? I think Nina said to help communicate with providers or something like that. All right. What else?
Patient safety.
All right. Yeah, it's already on the slide, right? Patient safety. Okay. So this was developed for improving patient safety. Okay. And so nurses use this, pharmacists use, lots of people use this to communicate information succinctly, to reduce errors, to make sure that the listener is understanding, what it is you're telling them, and so they can do whatever it is you're suggesting to them. So what are some negative consequences of not communicating in this format when it's required? Okay, arguments can happen. Yeah. What else? Patient may get the wrong medication. Okay, so some errors may occur. What else? Yeah, and that happens a lot too. So maybe you do know what they should do, or you have a good suggestion, but for whatever reason, if you didn't communicate appropriately, they may not listen to you. And I think on one of the links I gave you in the required readings, what percentage of prescriber acceptance is does the literature say, I guess, when you use appropriate communication?
90%.
Yeah, 90% or greater. All right, so that's pretty high. Okay. So during this entire time, we're going to be doing a ton of practice, and it may wear on you is 3 hours of practicing. We've got the other faculty here, Drs. Wooster, Cook, and Sharpton, here to provide you guys feedback to help you guys improve your communication skills, and that way that when you have to do this, if you haven't started doing this already on your IPPs, then you'll be more equipped to do so. All right, so, oh shoot, hold on, let me enable all of the files. Give me a second. In the meantime, any of the professors here have any stories of either successful or not successful stories of the use of
think the key of SBAR is being succinct and giving all of the essential information. When I started out as a student, I thought that I had to give them every little teeny weeny piece of information, even if it didn't matter, because it made me look like I knew what I was talking about. So I get on the phone with the physician, and it was about a vancomycin dose. And I was like, well, based on this literature, blah, blah, blah. And I thought if I quoted like studies, they would be like, oh wow, this chick knows what she's talking about. And the doctor's like, okay, I don't have time for this. Can you just tell me what you want? I told them, and they're all like, okay, yeah, I'm not gonna do that, and hung up. So make sure that the information you're providing is essential, and make sure that the information you're providing is in a brief format that follows the SBAR. Because if you go off track, you try and sound all impressive, physicians, their time is valuable. They got a lot of patients to take care of just like us. And if somebody was calling you, blabbing on the phone and wasting your time, don't you think you'd be a little bit, you could say that politely? So that was my experience, was don't give too much information, give only the essentials.
Very good advice. All right, so are the files now on your Canvas pages? Yes. All right. So download the inpatient narrative, Act 1, and in groups of 2 or 3, I want you guys to discuss the scenario and then write out in SBAR format how you would convert that narrative. Make sense? So in your groups, just write this out in SBAR format. And then later on, we'll actually go through. You guys have to do on the spot.
There's 14 files.
If you go to that video link, there's one right there.
There's what?
If you go to the video link,
Mhm.
that with the audio thing, it's got pretty much a script on it. That might help. Like 46 plus
63.
63.
Yeah.
If you need more time, raise your hand. There's a couple of you. If you're done, raise your hand. Okay. Give you guys one more minute, then we'll discuss it.
So we don't have so far like a concern that she might have because of this attendance. Situation, like I mean, how do you phrase the thing? Like just I'm concerned that she might have an intracranial hemorrhage due to the fall and her and then background you would say after looking at her medication list that her
All right, so here's a couple volunteers who would like to share their S-bar for this this situation. Let's get 2 volunteers, or I'll pick. All right, Ashley.
Do I just list out like what I put for each?
Just read the whole thing out. Like, so pretend like I'm the person you want to talk to.
Dr. Jones, this is Ashley calling from the pharmacy. I have Dr. Miss Willis, a 63-year-old woman who has taken a recent fall and has recently become somewhat confused. She was admitted for a fall. She has a right radius ulnar fraction, bruising, a laceration to her head, and brief loss of consciousness. Hourly neurovascular checks and repeated CT scans have been done. I think she's got a possible intracranial hemorrhage due to the fall and her daily use of warfarin. I'd like to get JW, a CT scan stat, and an INR.
All right, thank you. All right, any comments about that? Too much information? Too little information? Was your thought pattern clear? As a listener, did you understand what's going on with the patient, who they were, and what needs to be done and why? Comments?
Did she say that she thinks she was injuring?
No? Okay. Okay. All right, need one more volunteer.
I'll do it.
All right, Alex.
Dr. X, this is Alex calling from the pharmacy department. I have Miss Willis, a 63-year-old woman who has become confused, changed from her last neurovascular assessment. She was admitted for a right radius ulnar fracture, bruising, laceration to head, and brief loss of consciousness due to a fall. She regularly takes warfarin 6 milligrams. I think the change in her assessment may be due to a possible intracranial hemorrhage due to her fall and use of warfarin. I'd like to request a CT scan, stat, and get an INR.
Thank you, Alex. Comments about that one? What are the differences between his version and then Ashley's version? Different order, okay, so better, worse, no difference? Still effective?
Yeah.
You still follow? Okay. What other comments? Okay. So does that give you guys a general idea of what we're doing and why? But to me, I mean, they both seem pretty good. I was able to follow them and understood what was going on. The only comment I have about maybe on Alex is maybe orient me to the patient a little sooner. But other than that, I was able to follow. Any comments from you guys?
I like that Alex correlated, so both students mentioned that she was on warfarin,
Mm-hmm.
but I liked how Alex correlated the warfarin with increasing the risk of the hemorrhage.
Yes, yeah. So good job. Any questions? All right, so we'll do a couple more of these. Hopefully it'll be quicker. All right, so the next one at 2, and then after we do 2 of these, we'll go with, we'll start like verbalizing everything with one another, okay? So next one is gonna be outpatient scenario. So work this one up. raise your hand if you're done. Anybody done? No? Alright, let's get one volunteer now to read out their SR for this situation. One volunteer. Alright, Auburn, can you share yours? I think you were the first done. I'll give you the mic.
We just said that the situation would be the drug-drug interaction, but we were debating because we think that he's controlled on this medication and he hasn't had any muscle pain. Why are we calling? Because the physician's just gonna tell us, well, is he having a problem? We're gonna say no, and then he's gonna be like, why are you calling me?
So, good question. However, in this situation, for patient safety now, there is a little bit of debate as far as whether warrants are called. Let's say it does warrant a call. We do know the literature says it increases the risk of myopathy with the using above the FDA recommended dose on the simvastatin. So let's go with that one. So you're calling me on the doctor. That's a valid concern. So the doctor may say that. So you're calling me. So what are you gonna say?
John Smith has been taking
Who are you?
amiodarone and pharmacy
Who are you?
at Walmart. Hi. John Smith came to pick up his amiodarone and simvastatin. We noticed there's drug interaction between those two at his current doses of 200 milligrams and 40 milligrams of simvastatin. He's been taking them together for several months without complaints of muscle pain, and he can't afford any other statin. But current literature suggests that co-administration of these drugs increases the exposure to simvastatin, which increases his risk of myopathy. And I'd like to recommend that we reduce his simvastatin dose to 20 milligrams.
All right, questions or comments about that one? What is your assessment of her S-bar? Would you buy that if you were a physician? Don't care? Yes.
We were also like trying to figure out how do you know what to put in the background and what to put in the assessment, because we were kind of confused on like the fact that literature said that simvastatin is, it increased the risk of myopathy. Would that go in like the background, or would it go in like assessment, or the fact that he hadn't had any muscle pain? How do we know what goes with?
For that one, actually, I've seen them used in both. I would say that it's more of assessment than background information. Like the background information, just like what's he on, whatever, right? But your suspicion is you think he's an increased risk, because of what the literature says, right? So you can use that as your, I think, according to literature, or I feel like he's an increased risk of myopathy with his current dose of simvastatin, which is consistent with what the literature says. Therefore, I recommend that we reduce simvastatin to 20 milligrams once a day, which is what the FDA, states or mandates or recommends, something along those lines. And I haven't had anyone push back from that. I don't know, in practice, do you guys, would you guys recommend that change?
I would, because when most doctors hear the FDA says this, they know, ooh, if something happens, I have a lawsuit on my hands. So most doctors are very receptive to those types of recommendations.
Yeah. When I think I'll only remember one time for this particular one, and the reason I put this one in there is because when I was a student, that was probably the thing I called on like more frequently than anything else. So it just stuck out of my mind. I only had one person say, well, he's not, doesn't have any myopathy right now, and blah, 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 so I'm not gonna, change the dose. But at least you've done your due diligence. You can press on a little further, but at least do your due diligence. So guys, that makes sense. Any questions about, yes?
I have a question.
Uh-huh.
So what if like reducing the dose doesn't help reach his LDL goal?
Oh, so that's a good question. All right, so dose reduction, still not at goal. You guys have had lipids or not yet?
Yeah.
Yes. Okay. So let's say his LDL is still, I don't know, like, 175 or whatever. He didn't really get the 50%. Really? He's in bad shape. Sir, you're in horrible shape. All right, you're at severe risk. Your 10-year ASCVD is like 22.5%. Then what could you do, right? So there are a couple of different options. He mentioned, so thinking about patient-centered treatment and stuff like that. He said he can't afford any other statins. So what could you do? What are some alternatives you have in this situation where a person's not at goal on their current statin? What do you want to do for them, and then what do you want to tell the doctor?
Yeah, I don't think simvastatin is the cheapest statin out there. There probably might be some of the statin that is maybe the same price or as simvastatin. But that said, even if that is not the situation, then maybe we can look at the other medication, because I think amiodarone is not a choice made for that is often prescribed because of maybe the side effect and drug-to-drug interaction profile of the medication.
Okay. Some things you could potentially do would be like to see if there's, especially because this is an outpatient, right? So, are there prescription assistance programs available? Are there coupons available? Could a person potentially add on another therapy like ezetimibe, which is still controversial, but it's out there, to lower their LDL, lower their risk. There are sometimes you really can't do anything because a person can't get coupons, can't get prescription assistance. In situations like that, you just do what you can, but you want to see if those options are available for this patient to see if you can reduce their cholesterol to closer to goal. That's a good question. All right, so one more paper one. So this one is a little bit different. It's actually a transcript of a conversation. So read through this, and you guys can discuss this with your group. So you sift through this, and how would you convert the information, pull the pertinent information from this conversation, and communicate it to a provider using SBAR? If you're done, raise your hand. Are you guys about half a minute? All right, let's have one volunteer to share. Who is willing to share? All right, Ms. Hallbaker, you will share.
Hi, Dr. Jones. I'm a pharmacist at Walmart, and I wanted to discuss the therapy for Robert Queen, date of birth 1/1/1965. He came in today and says he developed a dry cough about a week ago, and he reports that it feels different from when his asthma acts up. He is currently taking lisinopril 20 milligrams for his blood pressure, and a common side effect is a dry, persistent cough. I would like to recommend switching him to losartan 50 milligrams, which should have similar efficacy without the coughing side effect.
All right, thank you. All right, comments about that one? Comments, criticisms? Too much information, too little information? Perfect, all right. You have a supportive friend over here? You guys friends in real life? I'm just kidding. Okay, so, yeah, pretty much, I thought it was a good job as well. Told about who the person was, what symptoms. You helped the physician rule out that maybe it's an asthma exacerbation. So you did a slight differential there. You also gave him what you recommended. And this probably is after the statin adjustment. When I was a student, it's probably the second most common call I had to make. Was people coming in with a cough associated with ACE inhibitors. Okay, so in essence, this is general gist what we're going to be doing all for the rest of the day. So any questions about what we've been doing so far? Okay, so I think most of you have downloaded this assessment form. It's not for grade. This is just for when you guys give feedback to one another. Just make sure that as you're watching your partner, that they very clearly provided, the SBAR components. That their recommendations were specific and not general. So in the losartan recommendation, I would have added in, the dose. I don't know if I remember if you said it or not. But that way, because they may ask, well, what dose do you think? So that way they don't have to really, you minimize the questions they ask for as far as clarity goes. Was the person giving the information all over the place? Seems like you guys are all on the right track with being clear and direct. So just anyways, give feedback to one another. And so here we go. All right, so what I want you guys to do now, and the professors will walk around and give feedback. Here's the scenario. You're at CVS Pharmacy in Juan Morales, date of birth 1176, brings a prescription for Zavesa for his newly diagnosed deep vein thrombosis. So when processing this prescription, you get a non-formula rejection. What does that mean for those of you that have had, I guess, DPs on community pharmacy or community pharmacy?
His insurance won't cover it.
And you're not going to pay for it, all right? So there's something else that's covered instead, okay? And so you dug around, looked at formularies, you asked insurance. So Sorrento is on formulary, and there's no reason for them to not use this, all right? So now in pairs, what you guys are going to do is decide what you want to communicate, how you want to communicate. If you guys need to look up some information using your drug info resources, you can do that too. This is not like a full-on story, but it just gives you a synopsis of what's going on. Then I want you to talk to the doctor's nurse this time, okay? Maybe the physician's not available, but Dr. Tyler's nurse is the one that's picking up the phone and can relay the information, but actually you're leaving a voicemail. So I want you guys to use your actual cell phones, okay, and call your buddy's cell phone and leave a voicemail. Then I want you guys to listen to it, okay?
There's no
Because
service.
then you can hear how you really sound. And this is going to help increase your confidence and build your skill in relaying information in a manner that the provider will listen to you. Okay? Because the last thing you want is for someone to play voicemail and like, you know, what the heck are they saying? Or like, they're going all over the place. Okay? So this forces you to do that because now you're being recorded and people at your group are going to listen to you. Okay? So go ahead and pair up, take turns leaving each other's voicemails, and then play it back, and then we'll go around and listen and give feedback. Okay?
Listen to him.
Or I need to look.
Look, it's so hot. What is that drug? I mean, it's not really a big problem. How are we supposed to recommend a dose? Acromatics.
What'd you do?
Oh, I sent the dosing for Xarelto. Because it's on the rubric.
Yeah, drug strength, dose frequency, duration. I like the name of that drug, Savasa. How do you say it? Sounds like it. It's Savasa, but it sounds like Cerveza to me.
Cerveza.
Yeah. Alright,
I'll-
ready?
I don't think I can call anyone in here. Yeah, I have 0 bars.
It's weird to like listen to yourself on the phone.
I like doing that. Are people like walking out of the room and calling each other? You know? That would be kind of funny. Like, you're walking, you're like doing stuff.
Tell my husband is he can't sit still and talk on the phone. He has to get up and walk.
I don't like that. I lose stuff when I'm on the phone. 'Cause I'll be doing stuff. It's like I'm sleepwalking.
Oh, let's see if he has some. Alright, you too. Okay. Thank you.
So most likely what will happen is
Want to hear it? That's the thing. You don't have to wait till it rings.
No, she read it.
there's like a starting dose.
Just has to have to listen to her.
Press 3 to.
So they don't send
Here's Lindsay. This is Lindsay with CVS
Voicemail
Pharmacy
full.
calling regarding patient Juan Morales, date 1/1 of 76. When processing the prescription for Savasa, noticed that the insurance is not and so it is that Xarelto is covered by the patient's insurance and the patient has no contraindications for its use. So I would like to recommend that the patient switch over to the Xarelto. And so if you would please talk to the doctor about it and then give me a call and get this patient taken care of. Thank you and have a good day. My GroupMe thing wasn't pulled up.
Oh, you did?
No,
You
it's
can't get
on
the
my phone.
dosage?
Yes, I should have written it
I'm
down.
gonna call you, okay?
Okay.
I don't have service.
No, not really. So I didn't get recommendations.
Everyone's outside calling each other.
This message is for Dr. Tyler Jones. This is Alex, the pharmacy director. I'm calling you guys to Juan Morales, date of birth January 1976, and his prescription for
If I could, you know, if I would have written down the dose and things like that.
I'd like to work on we switched from Savasa to Xarelto, 15 milligrams by mouth, twice daily with food for the first 21 days, followed by a doing that by my daily with food and taking at the same time. Thank you for your call back.
I don't know how to send it straight to voicemail, so I'm sorry you had to wait on it.
Oh, that's all right.
Alright.
Yeah, so it depends on how.
Mm-hmm.
I can call you.
You call me? Good luck getting a hold of it. I'll probably go straight. I'll probably go straight to voicemail. I'll forward it. Why you coming up? I was gonna put it on airplane mode. Oh, I'm actually getting a call. I got one bar.
I said 20. I don't know
Voice
why I
all
said
stupid.
20.
That's okay, you changed it back to 20.
Yeah, I did.
So I think it's still clear. No, I think that was really good.
Did you say the month and the day and the year, or did you say 1/1/76?
I said 1/1 of 76. That's how I called it in for prescriptions when I worked at the dental office. It's just habit for me.
Was it too fast or was it good pace?
No, I thought it was really good pace. Yeah. And it was clear. You could hear you. You talked really well in the phone. So I didn't see anything wrong with it. Did you get a price?
I just did.
What?
Alright, Bryce, you're gonna have to call Alex.
Call it.
You playing it back or calling?
I'm playing back. So hard to hear.
Yeah, I can't hear it.
You were like right there too.
There's not good reception.
It really isn't.
Maybe if I was like that, I could hear it.
You can hear Brett better probably there.
A little bit, yeah.
I like this activity.
Yeah, this is kind of fun. I like it.
Oh, you didn't say. Did you say anything about the GBT? Who am I calling?
Recently diagnosed.
Or Savesa.
My problem is the situation in background. I don't know how to do that.
Huh?
I suck at the situation in background. I'd rather just lump them into one thing and just be like,
I
hey,
think you can.
why not?
Yeah, I think you can.
Do you have to give them the date of birth or do you just give them the year?
No, you need to give them the date of birth
Like
because they have
how old they
registration
are?
identifier. They're going to look up anyway.
True. What date of birth?
1/1 of 76. Better call.
Who am I calling? I'll just call you back. Don't you dare answer.
Alright, who has not had a chance to either call or listen You ever called or listened?
I haven't called.
But you listened.
I don't have service.
Okay. Who has not called or listened? Okay. So,
There's just a dialing.
first of all, what questions do you have? I had some questions as I was walking around. What questions do you guys have about, like, I guess what this, yes.
So in this situation, they're switching from Savesa to the Xarelto, but we don't know the initial dose in the Savesa from the information that you gave us. So do we need to make the recommendation for the Xarelto with the dose frequency and all that other stuff? Like looking it up even though we don't
Okay,
have
so yeah,
the
so at this
frequency?
point in time, you guys haven't had anti-coag, so you wouldn't really know the dosing and stuff like that. But I was telling another group that if you were to do this exact scenario in real life, the Savesa dose at this point is irrelevant because you're not adjusting the dose of Savesa, you're actually recommending a discontinuation of Savesa and initiating another medication. Because that Xarelto does have different dosage or different strengths and different regimens, then you would want to tell them specifically, use this dose, use this regimen, and put that in your voicemail so they don't have to call back. Especially like when you guys learn DBT treatment, you'll learn how to initiate Xarelto and do that. So you should put those in there. Some people just said switch to Xarelto, but you really do, again, for stuff where there's a specific regimen that you want to minimize the errors that may come back. So let's say the person sends the wrong thing, which I've seen that happen. Had you told them what to do correctly in the beginning with the specific prescription, then you don't have to call them back a second time because you're going to get less buy-in with each subsequent call about the same medication or the same problem. There's another question someone asked about, well, how do you phrase the recommendation? Like, do you say, can you do this? Would you like to do this? I recommend doing this. I've heard them all, and in my opinion, that it really depends on your rapport. If you were to say, to me, I feel like, I recommend X, Y, Z is the more forceful. Some people are not comfortable saying that. I use it a lot because I don't really get pushback when I say it, but other people, depending on who the provider is, they may get some pushback because essentially you recommend it, but you've taken the choice out. So some people feel more comfortable saying, what do you think about blah, blah, blah. You still have your same recommendation, but you just change that introductory phrase. You say, what do you think about this? That way it leaves some decision making on their part, even though you've told them what to do. Or can we do X, Y, Z? To me, those are all appropriate as long as you are very clear with what your request is and not just making some vague thing and you're not very clear at all. Do you guys have any comments about how you guys phrase?
Just like Dr. Yu said, your rapport, really know what your rapport with that physician is. So if you have a good established relationship with them, you're calling them often, you've talked to them before, then you can go with the I recommend. That's a good way to go because it's very clear, it's very direct. But if this is your first time talking to that physician, you're gonna want to say something like, consider, like, because you're somebody they don't know if they can trust you. And yes, you're a good pharmacist for sure, but they don't know that yet. And so you just have to get that rapport established before you make a really solid recommendation to them. And next time they call you, you can say, I recommend. But the first time you call somebody, just make sure they easy to do it.
Yeah, that reminds me of a story like, so when I first was working as a pharmacist, I was in a small town, and there was this physician, and I was so gung-ho recommending all this stuff, and I did exactly that, using the I recommend, and this person did not know. They knew everyone in that town, right? Or the physician did. And so who's this male pharmacist coming in and this give me recommendations left or right? And they call my pharmacy and pretty much who is this guy? And so I had to change my approach to do the consider or what do you think about? I think I started using the what do you think about instead to make it more palatable. And then later on, once they realized that I was pretty spot on, then I started changing to being a more direct. And they're like, oh, what do you want to do? I'll just go ahead and do it. So that's really important to be able to feel your prescribers out. Okay, so who felt like they had a good voicemail? We'll play for the class to show you guys a good example. No one was good? You had a good one? Okay. Can we play that one?
Dr. Tyler. This is Dr. Hoppaker at CVS Pharmacy, and I have a concern about the therapy for Juan Morales, date of birth 1/1/76. He brought in a prescription for Cerveza for his DBT, but it is not covered by his insurance. After doing some research, I found that Celso is covered and the patient is not contraindicated. An initial dose of 15 milligrams twice daily with food for 21 days, followed by 20 milligrams once daily with food, is a common dosage for it. I just wanted to let you know about this, make that recommendation. Call me back and let me know what you think. Thanks.
All right, thank you. All right. So comments. What comments do you have about Holly's voicemail? What did you guys say?
Did she leave a phone number just in case it's like an
I think she said call us back, but did not leave a phone number. I did not leave a call back.
What is CVS?
Which CVS pharmacy? I don't know. All right. That's good though. Leave a callback number. Very, very important. Especially if there's more than one CVS in town. And Mr. Morales has actually shopped at multiple CVS's. Okay, what other comments? I like your use of not covered by insurance. I've heard some people say non-formulary. And so just like with patients, you want to minimize the jargon you use because non-formulary may mean something to a provider, may not. So not covered by insurance, everyone understands that. Okay, so let's get on that. What else? Like that you gave the dose. Toward the end, it was kind of unclear what you wanted them to do exactly, and then you said what you wanted them to do. Then you said, I recommend basically what I said before, something like that. It was a little bit awkward, but it's your first time, so it was good. All right, any other comments? Okay, so from you guys, any comments?
One thing I would recommend, just because, I mean, you guys haven't had anti-coab, right? Yeah, in therapy. One thing I would recommend is, if there's a drug that you know is renally adjusted, being in CVS, we don't know Mr. Morales' renal function, so I would say that dose, and then I would say, this is a renally adjusted medication. If Mr. Morales' creatinine clearance is below this level, I can provide you with an alternative dosing. That might be too much information, but maybe just say, this drug is renally adjusted if Mr. Morales has impaired renal function. Because sometimes the doctor might be like, all right, let's do this. If he's on dialysis, then it's like, ugh. So make sure, yeah, I don't have that information. That's just me.
Yeah, so getting their clinical parameters or making recommendations based on not knowing, that's a good point. Anything else?
So this is fresh on my mind from yesterday in clinic. We had a medical student that was visiting, and like her clinical judgment was pretty good for where she was in her career, but the way that she spoke was kind of like a high school teenage girl. And so she would be like, and then the patient was like, and then I was like, and then like, and it was just like, I can't take anything you say seriously. Like, to just, and I didn't hear anything like that going on, but just be mindful of how you present, make sure it's very straightforward and professional, that kind of thing, because it just, even if it's a good recommendation, it's just hard to take it seriously. If it's not delivered well, so.
Yes, thank you. Very, very important. All right. All right, so we got another one of these. So this is a little bit different. All right, so how many of you guys have had to like clarify a prescription or whatever on rotation or at work? All right, yes? No, I guess it doesn't matter how it came out, right? I need to clarify prescription. All right, so that's another phrase. If you haven't worked in a pharmacy yet, and a clarify is usually referring to issues where maybe you didn't really know what the doctor was doing, or something seems to be off and you're unsure about something, whether it could be like clarifying an illegible prescription, or clarifying a sig that seems off to you, or clarifying missing information. So that's another common phrase you'll hear on the community pharmacy side of things is, in addition to, I discovered a drug-drug interaction. Oh, I need to call to clarify a prescription with, with Dr. Tyler. Another thing I didn't mention, is a lot of times you, in community side, you may not actually talk to the doctor directly. You'll probably talk to the nurse. So I usually say something like, hey, this is Dr. Yu from Walmart Pharmacy. Can I speak to Dr. Tyler or his nurse, please? So that way, like, I said that I would like to speak to Dr. Tyler, but I'm also okay with speaking with his nurse. Because sometimes students will say, oh, I got to only talk to the physician, and they're like busy, they're in clinic already, they're not gonna talk to you, so don't feel offended if it's their nurse taking the call, they're gonna relay all that information. And so that's, again, another good reason to use it as far as because the doctor is getting the information secondhand now. It's not coming from you, it's coming from the nurse who heard it from you, so you wanna make sure that they heard you appropriately. Does that make sense? All right, so now, with this one, I'm just gonna tell you there's information missing. It's up to you guys to determine, or you can ask your buddies what is missing and what you need to do with the physician to clarify the prescription, okay? And go ahead and you're going to actually call one another, but not leave a voicemail, but actually have a dialogue this time, okay? So you guys need to step out in the hall, take a professor or two with you so they can all be monitoring, or you guys can go out. You don't have to stand in front of the other people's offices, but just go out to the side where the study rooms are and do that to make it, I guess, more quiet. So it's not you sitting in front of your buddy holding the phone and just making it awkward, okay?
So.
How long are they supposed to be taking that?
Yeah, and administration too.
And we'll take a break after this one.
And what's the dose? That's the same as, that's how much you're given, but like I'm talking like no, like the concentration of that. That's what I mean.
Well, we also don't have rules of administration.
Because I don't know, is this 875 concentration per TB?
But you're right, we don't have concentration.
Is it suspension? Is it already reconstituted?
It shouldn't be, not if it's a concentration. And it says dispense one bottle.
One what?
Size bottle?
1 teaspoon?
Well, I mean, we have to find out if it's a pill. It's gonna come to pill, right?
And it does, but it says TSP, so it's stable teaspoon.
Right, but then if it says dispense number 1, is it 1 pill? It could mean 1 pill. I mean, I don't know why you would take 1 pill, but.
Because there's suspensions.
Yeah, so it's probably a bottle.
Okay.
So he's not clarifying what milliliter bottle you're using and for how many days.
Yeah, because there's
3
one.
days, they take 2 tablets, 1 twice a day for 10 days, so disregard the rest.
There's literally 4 different suspension concentrations.
And I'm sure the bottles come in different sizes, like you're saying, so we need to know the dispensing quantity.
Yeah,
1 bottle,
milligrams.
yeah, we don't know that, so no refills, obviously.
So we need the volume and
Duration
the
of
dispensing
treatment.
content.
Yeah, how long are they taking this for? What's the
So
dose?
concentration, route of administration, dispensing quantity, and duration of treatment. Correct? For a therapy.
I don't think you need duration. You can figure that out.
No,
Based on the
because
volume?
If it's no, not necessarily, because with antibiotics, you give the patient like a full bottle, and that full bottle will last them a longer period of time than the duration of therapy that the doctor wants, like 7 to 10 days. That bottle will last
Okay.
longer than that.
So
depending-
how long is it supposed to take?
Yeah, that's why I think it's important. So, Dr. Tyler, do y'all want to go and study with you, or do y'all just want to sit here?
I'm fine here.
I don't like here either. Okay, just making sure y'all are all on the same page.
Are y'all calling still?
Huh?
Y'all still calling?
Sister?
Neither you can call me while you get a snack. Neither you can call me.
Call one another live. So we're not leaving voicemail this time.
No, we're having dialogue. So you have to answer your phone.
This is kind of funny. How do you play the other person? Like, oh yeah, it's 400 milligrams per 5 mils. I'm trying to give him 800 milligrams.
My patient's only 7 years old.
Yeah.
Ow, wow. Oh yeah, with dose adjustments for pediatric maybe?
But we don't know what they're treating though.
Yeah, that's a good one.
Sure. Is there like an app? I don't see an app on the app 6.
I had to take a picture of it.
It goes app 3 to app 6.
I didn't see one either.
So do we need to make a recommendation at this point, or do we just need to call for clarification? I would say we would just call for clarification. The only thing I might say is normal dosage is this.
Wow. BID.
You said you don't get service here?
I kind of do. I have like literally one bar, but I do get calls. It's really iffy. But yeah, right now 2 bars. 250 for 8 hours. Same twice a day.
So I guess we can just pick one.
I'm trying to figure out how you word that without sounding like a turd.
Oh, I know what the concentration this is. It's 250 per 5.
Yeah, one of these situations. Do you just ask for clarification, or do you say the normal recommendation is this?
I would say the recommended dose is this based on this. Yeah, so if there's missing information, kind of like they were talking about with the renally adjusted that you need, you could give both options. If it is this, then it's this. If it's this, then it's this. But again, we don't want to give too much information because then they're going to be like, I don't even know what you're saying.
It's overwhelming.
Yeah, so confident and concise, but also say, I'm like, for example, I'm giving you the dose based on making the assumption that creatinine clearance is greater than 6 years. You know, whatever those parameters are that may change the recommendation. Because sometimes a drug like won't be recommended based on kidney function or based on age, weight, etc. So you can't just be like, yep, this is the right one if there's some caveat to it, like age, weight, kidney function, liver function, etc. So you can say, assuming that, kidney function is fine, or assuming that. Because if not, they may just, if they do trust you, they may just take your word for it.
And then amoxicillin, that's an antibiotic, right?
Yeah.
So we need to know a duration.
Yes, unless there's a total quantity. Because sometimes it'll be like number 200 mLs or something, and then you can figure out how many days it is based on doing the math. But if it just says 2 teaspoons BID, but there's no total quantity, then you don't know how many days. Sometimes it'll say until gone, but if there's no total quantity, then that doesn't work. So if they said 2 teaspoons BID times 7 days, you can do the math and figure out the total quantity. Or if they say 2 teaspoons BID until gone, and then they give you a total quantity, you can figure out the days. But if you don't have total quantity or number of days, you can't figure it out.
And then in this situation, do we have to write out route of administration they would assume that it's 2 teaspoons liquid form. Can you make that assumption?
I mean, that's the only way that that's taken, but
It's
it is
903.
something that's gonna be left off a lot. So if you wanna be a stickler, you can say something, but a lot of people are gonna leave it off. Yeah, because 2 teaspoons, I mean, an oral antibiotic.
I'm gonna clarify it for you, I guess.
Yeah, so I'm gonna ask you for what was the diagnosis?
I got this.
And you tell me one of the.
I'll
But
say
I mean,
mild,
say it's
moderate
on
infection.
Damsitra,
I kind of got it
and
right
say
here.
if it was a suppository or an oral agent, and it comes in the different forms, in the same strength, then you would be like, I need to clarify the route of administration.
Okay, so in a situation like this, probably don't need to worry about this.
Yeah. Okay, because it's often going to be left off. But if something's like a suspension that comes in an ophthalmic suspension, you know, a lot of those, you know, so you need to clarify, is this going in the ear or the eye, for example? It just depends on the product.
Gotcha. Okay.
And the formulation.
Well, thank you.
Sure.
Let's do this.
It was for mild to moderate infection.
Huh? Well, I figured you'd call me first since I went first last time. Okay. Here, I'll go outside. Okay.
It was 250 milligrams per 5 mils. It was written for 2 teaspoons twice a day of that. So that would be 250 milligrams twice for 1 dose, and then 250 milligrams twice for the second dose. So it'd be a total of I think 1,000 a day, just in 2 divided doses basically. And 4 or 5 days.
So, he's made off the medication that she needs to take. It's just safe and it's to read too.
Thank you. Have a good day. Sure. They actually didn't tell me the duration of use, but I just said 5 days.
That's good.
I just went with it. That was pretty simple. I mean, you just got everything you needed.
All right. What questions do you have about this activity? What was the hardest part about doing this?
Making up the physician stuff.
Over here somewhere. Get it out of your answer. Okay, well, you don't get it out of your answer. It's okay if they don't answer. Okay? So, oh, yes.
Yeah, well, you know, sometimes you might be tempted to assume some of the things, or some of the information. You know, so one of the problems might be which one of it can I just assume this is what it's saying, and which part do I now say I need a specific clarification of this.
Can you clarify what you mean by assume?
Okay, like he said, 2 teaspoons twice daily, dispense 1. So one of the things that is not clear is, okay, how many days do you want the patient to use it? That is using it. So do I still go ahead and ask the one you are talking about? Is it what size of bottle, or what is the contents? Or do I just calculate based off of how long the dose will last?
Okay, let me ask this to the class. All right, how would you address his question?
If I'm talking, I'd ask.
Okay, so, all right, so asking for the strength, asking for duration of therapy, you can back calculate, you know, what size bottle to use, because they're not going to know how it comes, right? But you guys can fill that information in. So the number 1 one bottle or whatever, you guys can figure that out. But you need to know what dose, you know, the concentration of the amoxicillin, duration of therapy. You may want to know the patient's weight so you can double check, indications so you can double check. What other information? What if the patient, so what is, okay, allergies, right? Very common allergies, penicillin allergies. So anyway, so all those informations you can ask when you clarify the prescription with the provider. Now, sometimes maybe you have some of the information. Maybe you know the weight, maybe you know the indication, maybe you know allergies, you know all this kind of stuff. So at times, you know, as you guys get more comfortable in practice, you may actually have a recommended dosing regimen, or you know what you carry in the shelf and say, hey, we got this, you know, based on what I calculate, this is what it comes out to be. Would you know, do this or whatever? You can do that as well. So the clarification doesn't always have to be getting information. Sometimes you have some of the information, but you can still provide a recommendation. Now, someone else asked, you know, SBAR, the R is for recommendation. What if you have nothing to recommend, right? In this case, you're just clarifying, you're just missing information. So recommendation, it is a little misleading because it's just, you know, it sounds like you're always recommending, but think of it as you wanting someone to do something. So there's some kind of a call to action. And so it doesn't have to be a recommendation. Like if you're clarifying, your call to action is, I am missing information, please provide the information to me. So would you please call us back with blah, 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 or send us a new prescription with blah, blah, blah on it. That is still a recommendation. You're still gonna use that same SBAR format. And when you guys are working in the hospital, nurses use the SBAR format to communicate, but they're not necessarily making recommendations. They may say, can we get an x-ray? Or can you come see the patient? Or blah, blah, blah. Okay? Does that make sense? Okay. Any comments? Anything you guys heard or? No?
I want to know Rick Grimes related to Gracie Joe.
Okay. So Rick Grimes is actually potentially going to be the adoptive father of Gracie Doe, who he found. Who he found in a room secondary to Gracie losing her biological father.
I haven't seen this season, do not reveal anything.
Alright. So no Walking Dead spoilers for Dr. Cook. I come back at 10:40.
I love
Is this Walking Dead references? I need a drink.
I was on the
Like from the comments, when from the series, I just start off with like, what is the technology that was developed treatment. So those 3 videos actually is like the majority of it. It talks about each class. What is a treatment for? So like, what are they trying to achieve as a child? Yeah, and then it's like A is on the other side. All under one.
Is that a rhetorical question? Yes.
Do I know what's up with home?
Yeah.
Shut up. That's some bad news.
I
She was
texted
here.
her and let her know.
She was this morning.
She was?
But she left. Well,
I told her we were here for her if she needed anything. She said she was driving down to Houston and thank us all for the support. So she's driving down to Houston.
Hope
It's her,
everything's
she said
okay.
it's her,
grandmother.
I think it's her grandmother. She said Big Mama. I'm assuming it's grandmother. She's still here, but she said it's probably going to be the last time she sees her.
I know how that goes.
There wasn't a passenger.
She's not yet. She's driving down to see her before she does. I think it's inevitable
Hopefully she makes it down there.
in time. Yeah, I agree. But I told her, yeah, like I said, that we were here for if she needed anything.
You working on it? No?
Can't get a grade on this test.
Yeah, I feel you.
Or even 82.
So these places, like, they let you work whenever you want.
I can go home. I've been with them for 7 years.
I mean, I tell them, you don't come as you leave. No, but they understand you're sleeping, right? That's good.
Like pressures.
I gotta plan an internship for the summer. I don't want to work during school. Work this summer. No. I hate it.
I like hospital.
I like
Back and forth.
But you've been working retail for 7 years, so that's why you're biased towards it.
I hate dealing with people. I hate it so much.
I don't mind dealing with people, but not the people that go to
Retail?
retail pharmacy.
That's what I'm talking about. I'll deal with people in the hospital all day.
Yeah.
Especially old people, they're so sweet. Except for the crazy old people. They're kind of terrifying.
See, you have to work for your pay in retail.
Well, maybe the hospital will be the same. At the rate that they're making us do all the soaps and stuff. If I get in the hospital and then I don't have to use any of this, I'm gonna be like, oh my god.
I guarantee you won't have to use soap. I mean, it's a different format. It's like all electronic. You
Yeah.
don't have to.
And they just half type it all in anyway. Like I've seen like 4 or 5 soap notes that are out of order. They'll put like APS in there.
Alright, so let's get back. Yeah, we're skip ahead a couple apps to app 8. This one does say, well, disregarding the first instructions on there. Alright, so what I want you guys to do now is download, there should be 3 different cases on Canvas that say app 8 on them. They're probably titled Ventolin, Xarelto, and Bupropion, something to that effect. Alright, there's going to be a pharmacist and a patient version. So what I want you guys to do is I need you guys to get in groups of 3 with people from other teams. Right? You guys have been comfortable talking to the same person the whole time for the first half of the class. Now we're going to mix up the people. Alright? So you will only play one patient. So let's say that you are the patient. And then whoever is playing your pharmacist will download the pharmacist version of that. Right? You guys are going to be trading information. You guys will need to do patient interviews, okay? So what I want you guys to do is, in this encounter, you get the pharmacist, the patient, and the provider, all right? And the provider can kind of double as, an observer or whatever. After you guys do the interview, following the prompts on these sheets, you're then going to communicate using SBAR whatever information you deem the provider needs to know, because there's going to be some recommendation you have based on your interview, because there's going to be a medication-related problem, okay? So, interview your partner, then the person playing the pharmacist, let the patient know you're going to call the doctor, then you're going to actually call your third partner, who's going to be the doctor. And so at that point, one of you guys can step out, I guess the doctor can step out, okay? And then you're going to call them on the phone, and we'll give you guys feedback on that. Does that make sense? Okay, so interview your partner, figure out what's going on using the cases, and then call the provider using SBAR, your recommendation. Okay, so get up, switch partners, find people from other teams. All right.
What's happening? You're so convenient right here.
I don't want to move too far. Do you want to? Yeah.
Yeah, come on.
Can I be the patient?
All
Dude, I'm still gonna be a little asshole.
I just downloaded the app 8, the very first one on the top,
I got all the juicy details over here.
Are the details on another page?
There's a patient copy and a pharmacist copy.
There's the patient copy.
I guess I'll be the patient. Are you gonna be the provider?
I'll be the provider. I don't know what I'm doing the first time.
Yeah,
I need to read it.
Ow!
So are we doing all of the 3 apps?
I think it's just app. We're gonna do app 8.
App 8, so
There's two copies. There's pharmacist copy.
So we can, okay, you want to do the first one? Yeah.
Oh, I guess he's here to receive your call and get the recommendation. And I'm just kind of like, hey guys.
Do you have a ticket?
I don't know.
You migrated all the way from there. And then up on your phone. Oh, so everyone's you can grab a chair.
Ventolin is the first one.
Okay.
Yeah, so it makes me feel like the Ventolin is easy to write notes or something.
So you can just yeah. So what's the provider agent? I think
This is specifically for stuff that's not on here. I'm supposed to say, I don't know. I don't know, bro. I guess I should see what information y'all have too.
Oh, I'm only supposed to do one part, right? And then yeah, I'll be the pharmacist to convey that information. Oh, who's gonna convey it? Because I was gonna ask questions for right now. And then
So that you're then the pharmacist.
but I don't get to.
That, okay, you can ask me and then you tell the doctor the information. Whatever you
So what is he gonna do?
He's gonna be the doctor.
Oh, okay.
The provider.
Oh, okay.
Because the pharmacist will interview the patient and then tell the patient problem that
Let's
requires
see,
a call
1,
to the
2.
provider.
Oh, never mind. He's got
Yeah.
he's got fluticasone, which is just the nasal spray. So he just has 2 inhalers.
You don't even have to. You can just
Yeah, for now, it just.
I was looking at what.
Yeah, but is that,
Flex, what
is one of them a corticosteroid?
I was gonna say, is he supposed to take the?
I think that one doesn't have. The only
the
pharmacist copy there
Ventolin,
is.
the Proair, is that
because he's supposed to have like the maintenance and then like the rescue inhaler, right?
Yeah. So
So-
the as needed is the Proair.
Yeah.
Yeah,
And
we
the
will do Ventolin. I was just cooking.
1 pound mouth every 12 hours.
So,
Maybe
like-
maybe the dose is wrong.
Because I think
Or
there's
something.
three.
Let me look.
Yeah, that should be.
Oh, okay, yeah, so sorry.
What's triggering me over here is the fact that does he have a corticosteroid inhaler?
I mean,
Is that the
he had is it-
Plimacort Flexihaler? Is that?
Let me see. Hold on.
If that's a corticosteroid, then that
Hold on
might
to the
interact
screen
with
to do the dog screen.
fluticasone
Let me
to
do
increase the
the
chance.
drug interactions real quick, guys. And I'll put on.
You know, I'm thinking thrush maybe. Let's see if I got anything weird going on.
Like that, and then you click whatever screen you want.
Cause I thought this was gonna be like a script or something.
That's what I thought too. Mental H.
Oh.
They did it twice today.
I think you hold it right there. Yeah, it is.
Oh wow.
What?
Okay.
Try this again.
Y'all should probably ask me about how I'm using my inhaler and what's going on.
Okay, alright.
Yeah. I'm supposed to find out what they are. Because you're allergic to codeine
Okay, pretty much do look at soap on me.
I'll be the pharmacist. I'm trying
Oh,
to,
so
I'm
you're
trying to
not.
figure
So
this
that's the
out.
problem. You're not taking it accordingly.
I
Or
think I'm having
Which one? Is
Okay,
it the
I'll just tell y'all, like,
Is it the flexion?
I'm just not, taking it too many times.
Instead of
Like, I'm having to take,
perfect. All right.
I'm using a few times a day, every day for the last couple of weeks. My rescue inhaler. So it is, I'm not controlled at all, basically.
Hey, is this Mr. Bryce? Okay, this is Dr. Tomlinson over at CVS. Just got a couple of quick questions to ask you about your medication. Is that okay?
Okay, yeah. Well, actually, I think I'm supposed to be in to refill. Like, I'm actually physically here. That's what it says on here.
Okay.
It says, I'm just here to refill this Ventolin.
Okay, great.
Stupid Ventolin.
Is that all you need today, sir?
I don't know.
All right, we'll get that for you ready.
Okay.
All right, I'm gonna ask you a couple of questions about your medication. What's your date of birth?
2/17/1972.
All right, what allergies do you have?
I got, I'm allergic to sulfa. It gives me hives.
Okay.
And codeine. It gives me hives.
All right, great. So you're here to pick up your Ventolin. What other medications are you taking right now? Any other inhalers or anything?
Pulmicort, my Flexihaler.
Do you know the dose on that?
180 micrograms. I think.
All right.
They would not know that.
What other medication?
Cristal, 20 milligrams. I take my thiazide and my hydrochlorothiazide. And some nasal spray. Fluticasone.
Okay. All right.
Flonase.
Fluticasone. All right.
That's one of my allergies.
So when do you take your Flexhaler?
Whenever you have those experiences.
How often? Are you taking that? Every 12 hours?
Which one?
The one that says Flexhaler on it.
Yeah, I'm just taking that every 12 hours.
Every 12 hours?
I don't really know.
Are you taking it more often than usual?
No, not on that one, no.
Oh, okay. How often do you take that a day?
And how about
just one puff every 12 hours, like it says.
Okay. What about the Pro Air, the Ventolin? How often are you taking that?
Oh, I hate that thing. I'm taking it all the time.
All the time?
I'm pretty much taking it every single time I go outside, wake up, go walk.
So when you say all the time, are you taking this like more than 6 times a day?
I'm using it a few times a day, every day for the last couple of weeks. Usually when I go outside and I start walking, and also in the middle of the night, for some reason I just need to take my inhaler.
Okay, all right. Well, I'll just go ahead and let you know that we need to get you set up with your doctor to figure out another steroid for you. Yeah, well, we need to get you set up with your doctor so that he can help you maybe adjust that dose of that medication or give you something else to help you with your sleeping. How long has that been going on? You've been taking that at nighttime?
Just the last couple of weeks.
Last couple of weeks. Right now, I'm gonna.
This is how you take it, right?
Yeah. Is he taking it wrong?
I don't know. It says be able to demonstrate appropriate techniques, maybe.
Oh, okay.
Yeah.
So he's here. Did you have your inhalers with you today?
Yeah, buddy.
Okay. Well, show me how you use it. Like if you actually have time to do that. But yeah, I'd probably go ahead and recommend it. You go see your doctor soon, maybe in the next week or as soon as possible. Get set up with him, just to see if he can recommend either upping the dose of your inhaler or changing to something else. Yeah, I'm gonna fax him over a note to your doctor, describing the situation. If that's okay. Also, what other questions do you have?
How do I take this daggum inhaler?
You're supposed to only take it, as needed. But if you're taking it more than 4 to 6 hours, if you're taking it more than 4 or 6 times a day, that's a problem. I guess 4 would be the max for this inhaler.
Well, I'm taking it like this. I go.
Oh, okay.
Is that right?
Oh, no, actually, I was going to tell you, you you actually need to hold it in for at least 5 to 10 seconds, preferably before you exhale. So honestly, I want you to try to take the medication that way, hold it in longer, and maybe it'll give you some better relief. And if that doesn't work, I'm still going to go ahead and refer you to your physician and see if we can get you something else.
Can you
Sound
call my
good?
physician? Can I get that done today?
Yeah.
Because I
definitely.
hate
I'll get this done real quick.
You're getting too
Just
into
like
it.
do it improperly, even though you told me how to do
You're a
it.
good actor.
Yeah, right.
Pharmacy still doesn't work out.
All right. If you want, you can call me and.
Check up with my doctor.
All right. You want to be the pharmacist, right?
Oh, I'm still the provider. You're going to convey all that information.
Yeah, and I'm
that
just
you
waiting. I'm
Yeah.
just waiting and
Okay,
reading my
that's what you're
paper.
supposed to do?
Yeah. So just do it like the bar. Just go through
All right,
a little
sure.
synapses.
I got my little newspaper
All
over
right.
here.
I didn't write anything. I'm just gonna try.
That's it. Yeah. You're good. You're good.
All right. Dr. Tyler, this is Hayden over at Walmart.
Okay.
Just have to relay some quick information to you, if that's all right.
Sure.
I had a patient come in today. He's on 2 inhalers.
What's the
I
patient's
figured-
name?
Sorry.
Oh, you can come make a
Patient's name is John Doe. Date of birth 1/12/1962.
217.
Whatever.
Oh, we have him as
1970.
2/17/1972.
Okay, yeah, that's what I have here. All right, and he's taking he's on 5 medications. He's taking 2 inhalers right now. I showed him how to use his Ventolin correctly.
Okay.
He wasn't holding the dose in long enough, so I counseled him on that. That should help him. But he was experiencing. He was using this inhaler multiple times a day. I'd say 3 to 4 times a day.
Oh wow.
Every day for the last couple of weeks.
Every day for the last couple of weeks, and he's also having trouble sleeping at night due to his shortness of breath.
Okay.
So I was gonna recommend that maybe he come in here the next week or so, if you guys can make room for him, just to go over his medication and make sure we don't need to up his dose or change the medication or anything like that.
Okay.
Is that okay?
Yeah, that sounds about right. As long as we make sure that he knows when to use it and as needed. I'm sure you're gonna go over it once I send the prescription again.
Yeah, absolutely.
But I do. I think that's the best thing. We don't want to exacerbate any other issues.
Okay, yeah, that's the play right
Could you
there.
recommend spirometry too?
Well, they'll do that.
I don't know much about
yeah,
I don't know.
you
Was
can
he?
say that to him.
Is he he's COPD, right?
Asthma.
Oh, just asthma.
So could you say, hey, go in and let's see if your spirometry changed at all?
Sure.
Yeah. Say I don't have his spirometry levels right now, but I'd probably go ahead and get that test done compared to his.
Yeah, he's scheduled for next week, so we'll go ahead and run that.
Okay.
And make sure that is on the up and up. And also, we will reiterate as far as training goes, when to use it, how to use it.
Yeah.
I think that's the key thing. But
Yeah.
I trust you can also do it.
Sure. Well, I'm glad I caught you at the right time today, sir. What other questions do you have for me right now?
Nothing at this moment. Just let him know that. Just remind him about his appointment next week.
Okay. Sure. All right. Great. All right.
Perfect. That's awesome.
And then I'd come over, are you done yet? Damn it.
Quick and easy.
So the next one
Are we gonna
is
do
a
the application 8 or 9?
the Xarelto.
Yeah.
Oh wait, this is Xarelto, right?
Yeah. I don't know about you. That is the next one.
Nigeria, by the time you get up from the airport, you must have lost just 2 concepts. Because the amount of
Figure out the problem for me.
Like if you go see the like in
Most now do, but not all.
well, no, because they you could literally like they're nice really cold. Yeah, the heat is so different.
wet, like from outside inside. back outside.
So you do a song
No, they're coming from, your brother that just said to this.
So do you want to be the pharmacist and not be the patient?
Sure.
And then Hayden would be the doctor.
Tyler, environment question on that.
What do you mean, environment?
Like the season, the heat, the winter time.
Spring is worse than anything else here. I would say that. For me, at least, spring is worse because there's so much pollen that comes from these pine trees.
Okay, so
And allergies, that's why like Ben Fish came to Tyler to start practicing because he had a specialty in allergies.
It's Houston and Corpus Christi that have factories like that.
Houston, the environment, not from the trees, but from like the factories. Yeah, it's gotta be. It seems like every time I'm in Houston, it's either raining
so you were saying that
or
the
it's
person
just overcast because of the damn
excessively
smoke.
using the ventilator.
Yes, sir.
And you're saying the
I'll find an error.
Yeah, I'm
protocol is
actually
not
I'm looking
actually
up to see if there's
helping
any
to stop
drug interaction in here.
the patient's exacerbation.
No, the patient's ventilating is
It's not working to prevent exacerbations and the well assessment are working for it. Okay. And what do you recommend that we do for this patient? No, yeah, that's Dr. Doe. They do. What is your recommendation? Because you pointed it out. You brought it out. I don't think it's about you.
It's not probably the same. This thing is weird.
Yeah, so
Got the
to me, I just thought the patient
Yeah, for
start
deep
exercising,
vein.
doing aerobics to increase the lung compliance.
I don't see any drug interaction.
You see the.
Well, if she's taking
Maybe there's something wrong
the
with the throat.
Ventolin, the rescue,
Maybe do the disease state and put in.
what
Oh,
we're
in
supposed
fact
to do is
comparison?
Yeah,
increase the number of bottles.
What's the disease state?
deep vein thrombosis.
Where is that on the pharmacist copy?
They'll see that maybe she has adapted to
Oh, I guess I'm supposed to call
Ventolin and switch it to
and get that from the physician?
Pro Air or Proventil.
But you're interviewing me, right?
That's what they'll do.
Isn't it?
Pulmicort? Is Pulmicort the combination, right?
No, there's actually no.
Yeah, what'd your doctor tell you before? Huh?
Yeah.
Oh, deep vein thrombosis. Like, no, they'll be like, I have no idea.
Symbicort.
Something with my neck.
He says occasional
Can I use
marijuana,
that
a couple joints a week.
I don't know.
Social history.
What?
That's why we can either switch.
He's missing his dose of venlafaxine.
He's missing his dose?
He misses a dose of venlafaxine once a month.
Oh, that's the problem.
Yeah, I think so. Maybe
Run
there might be something.
what do you call it? It's a test. Respiratory test.
So the Ventolin,
FEV
or
once
if, it's any just inhaled corticosteroid, overuse of that just means that their controller med for long after is not at a correct dose. Or maybe they're not using it as directed. It could be inhaler technique, it could be inadequate dose, but of the controller med, not the rescue.
There you go. But it was the technique. It was the technique. Did he say?
Yeah, so if they're doing proper techniques, yeah. So just always know that if they're like using their Pro Air too
Last one, his
much,
technique was bad, right?
it's because their controller medication, they're long acting.
Well, I kind of made it that.
You guys have to have correct.
It was kind of vague in that patient thing.
Rescue overuse indicates that controller long acting is not, either they're not using it correctly or the dose is too low.
So it was the other one. So either
Controller
way,
medication was
I made a
messed
good
up.
recommendation for Oliver
Not the
for
rescue.
him to figure out, to talk about his two medications. So the doctor could have picked that
That'll
up.
be up to the doctor, but I would say,
I
according
didn't
to,
switch anything.
my
I just said,
conversation with
was
the
that-
patient,
So what is in the controller?
they're
patient
needing
needs
the
to
rescue
be
inhaler,
able
which is
to
Pro
figure
Air.
out if
The
Not
other
using
one,
correctly.
not the Pro
That
Air,
shows their asthma
the
is not under
Ventolin, that was
control.
working fine.
They're currently
I
on
didn't
this
make the right
dose or
recommendation.
as
He's
they're
using it
whatever they're
to
on. And I
So
would
it shows that
recommend
his like
increasing the
maintenance
dose. Or you
medication
may want to
wasn't
see in the
controlled controlling him.
let it
So
be
he's
up
out
to
of
them. I
control.
won't make the dose
Because he's
increase
out of control, he
recommendation,
hasn't
but
used.
they may wanna
So
see
he
them
was
come in
using
and
the
come in.
rescue inhaler
Okay.
Those increment
more
Just depends
often.
on
Yeah, because his controller medication, like
the
his
long
LABA,
acting,
Yeah.
yeah. So if, that's why we're like, how many,
or whatever,
oh,
probably
you're
not a
coming
lot.
back to get your
was just lasting
Just
too long.
his maintenance.
How are you
His
using
maintenance
it?
was.
Oh, I'm using it
Yeah, it just
this
was
way.
being 2 week for him.
However many times a day.
I
Maybe we're
forgot
doing
the
4
problem with the
puffs,
air, is
5
the air.
times a day. Who knows?
He's missing his.
So if they're, that's the
Missing
big
those?
red flag
Hey,
indicator that
his
their
last
asthma's
bill
in
date
control.
for
They're
his
coming back
program
frequently
was
to get
6/12,
those
16.
inhalers, which
Here we
are
are,
often getting
2017,
tipped
so
off because,
maybe
oh, why is
that
insurance
outside the
rejecting
box
it?
code
Because
is that he
you're coming
hasn't
back
got
more
that
frequently.
He hasn't got, but
Then
It says
you
that
should
say it's
be, and it's
controlled,
because we
his,
need to increase
I haven't used the rescue
the
inhaler though.
acting agent.
Okay.
Since it was, or the patient, he hasn't used it since
hasn't
it was
used it
prescribed.
since, so it's fine then.
So
Has he had any exacerbations?
no. So
the Pulmicort, what is better than the Pulmicort?
he doesn't no exercise diet.
I mean, isn't it dose?
Drug
They
use.
increase it if they want to.
The highest strength.
It's just for a DVT of left leg. So what's the issue?
The McCord is the
I don't know.
Just that the destination is a Yeah, I know that Pulmicort name threw me off a little bit.
Is that the right dose for a DVT?
There's no interaction.
There's not an interaction.
So Symbicort is like
Is there any interaction with like food he's eating or anything like that?
Salmeterol and something.
It doesn't really say about eating. It doesn't say anything.
Yeah.
What purpose
Oh, wait.
are we gonna serve? Like, what's your idea?
It's 15 milligrams orally for the first 21 days.
Well, yeah.
For Xarelto?
And the lava long acting.
I don't know if that's it though.
He ain't giving it.
I guess that you'll recommend that to them and then.
Okay, let me call in for
He's got 2 different prescribers. I don't know if that is anything or not.
No, because they're different prescriptions. It would be different if they had.
The same prescription. Yeah, you're right.
TID has in it. Okay, that's just for one time dose.
Is
And after
Venlo-
that, for the patient.
Fine, I'll just put in Xarelto and see if there's.
Hey, does marijuana,
Yeah, I was
does
about to.
marijuana have something to do with his social phobia?
Oh,
No.
I'll do it.
Or like, yeah.
Not if he's at parties.
So we have some with insult.
I can't seem to find the problem. So 2 puffs by now.
How do you ask him how he stores his medication?
I don't know.
Maybe he keeps them in like a latex bag or something. No, I'm just kidding. I'm joking. I'm joking. I don't know. I'm just trying to think outside the box right now. Have y'all done the Xarelto one?
No, but
He's got asthma, but he's smoking. Is that
He's got
bad?
social phobia. Hey, he's got social phobia, but he's been
But he says he hasn't used his rescue
every week.
inhaler at all because he's not smoking
He's got
cigarettes.
social phobia. Maybe that's outside the box.
That's pretty funny.
More paranoid.
He doesn't say that specifically, but yeah.
I'll be like, sir, you smoking sativa or indica? Do you know? You know what I'm talking about?
He's going to
Sativa or indica?
That is different.
Those are like 2 different types of
Are you smoking that keef or the extracts, boy? What? What are you doing?
You need to go your old fan, okay?
You're like, I got a store down the street if you want to.
He's like, I'm playing too.
Huh?
No,
They're both
it's different.
I don't know.
It's like crossbreeding and crossbreeding and
No, that's not.
Is there a hybrid or is it a pure extract?
The hybrid is
Or is
hybrid
it
is cross.
is it CBD or is it THC? I want to know the percentage.
Recommend CBD over.
Yeah. Recommend CBD for medical
Has, like,
benefits
osteoarthritis or anything.
and anti-inflammatory
you can try
properties.
this. What if you gave that recommendation for the whole class? I would laugh.
Recommend CBD because it'll chill you out a little. It'll get rid of your social phobia because it's not psychotic.
Yeah, yeah.
It's just that you
I want to
have
move to the next one or what?
your asthma though. I still don't know his problem though.
Y'all already checked the
Yeah.
doses.
Is
Correct.
it the
I guess we'll
particular
just
dosage?
swap them
Are
all
the doses
together.
right? That's all up in
It's
the
20, yeah, 20. Wait, isn't it 15?
It's
For which
15
one?
initially,
Yeah.
and then for 21 days, then you go up to 20. But I don't know why.
But he's getting
20.
20.
Yeah. I mean, I was thinking that's the error, but he said think outside the box. That didn't seem like it was really outside the box.
Wait, where does it say think outside the box?
Yeah, I know. It
Hey,
says think
hey,
outside
hey,
the box.
hey.
In the
hey,
pharmacist copy.
Hey, how
I mean, the
long?
patient copy.
Alright, never mind. None of these drugs are controlled, right?
Deep vein thrombosis.
None of these drugs are controlled, obviously, right?
Yeah,
I'm just
none of
making
them.
sure that
It was
like we need another prescription to fill this. I know you don't need to do that.
Okay, let's talk.
So 9.6 last fill was
Is Xarelto
Hello, doctor. My name is
Xarelto, yeah. Like,
Yes, sir.
I think that's the
just went to
problem.
see Dr. Benchakis and I was diagnosed with
Sorry, I can't hear you.
Uh-oh.
See, don't you?
Uh-oh. Vinland vaccine and
And what?
Xarelto.
Interact.
I just went to Dr.
Result increased risk of bleeding.
great, great. Click that matrix right there, son.
Yeah.
See what they say about that. Yeah, we already got that. All right.
Okay.
Go back. I'll just go.
Yeah, there we go. There we go. All right, use caution. Can we try the other, Surveya, whatever? Talking in Cerveza.
Cerveza might work.
Cerveza might be better for him.
And do you have any allergies?
Because you're gonna have. Let's see if that's a good recommendation alternative.
Cerveza is an actual medication and not a
How do
beer.
you spell that?
SARV.
Why? Isn't it? Isn't it V?
It might be SER.
Hold on.
So is the drug interaction? Yeah.
BY. Try BY. No.
Nice.
Did you guys catch that?
Fuck this drug.
Yeah, we did. We're trying to figure out a good alternative.
So you're a good alternative for the.
Yeah. Alright, what are other good anticoagulants that we can use? How about aspirin? Aspirin?
Antiplatelet.
Antiplatelet, yeah.
You tried.
Okay.
Venlafaxine,
75 milligrams?
Alright guys, I've been getting a lot of questions on the dates of the prescriptions. I did not go back to edit these cases. I think I taught it in February of last year, so the dates are a lot closer to when they were actually having the class. So just pretend that the refill dates, pretend that the refill dates are closer to today's dates. So it's not that they haven't picked them up in like 10 months. That makes sense? Okay.
Never mind. Alright, how about...
So what medications are you currently?
Alright, how about try warfarin?
I know.
Try warfarin.
I am the patient.
No, it was in the part of
It
the.
ain't gonna work. It was, you gotta do the other one.
There's
Xarelto. I mean, do, it was,
Unfractionated heparin.
Yeah.
Singular, I can't pronounce that. 10 milligrams.
Antidepressants.
I take that night. I take
heparin sodium. Or which one do you
So
want?
you want to stick with that one?
I take 4 times.
Oh my gosh, really?
There's nothing.
What's a drug that's low molecular weight heparin?
We use Eliquis. Is that? Because this is long term.
I got some low molecular weight heparins right here, fam. How about enoxaparin? ENOXAPA. There you go. Nope.
There's a big nope on all those.
What about?
Huh?
They would have to, or they would stop the other interaction. Yeah.
It was venlafaxine, right? And all right, you want to try
I'll see
don't
what
think
the
any of these
recommendation
are
is on that interaction.
I don't know. I mean, I just feel like
Yeah, click on the actual. Yep.
What the fuck is happening?
Yeah. Well, I mean, depending on that. What about? Did you try Cerveza? Didn't come out.
Savayasa.
SAVA. Let's see if they have a recommendation on here.
Oh, on there.
I don't think they do, man.
And then or
5 years versus like 15.
It just says monitor the coagulation crap.
lower. What about lowering the dose?
He didn't say anything about that.
Yeah, I didn't say anything about lowering the dose. Try the drug interaction. How you spell Savesa
It's a
again?
blessing.
It is. Crap, hang on.
Why is he shaking
Spell that
so
fucking
bad?
drug.
I think it was SAY.
SA.
God.
Yeah, but
Hold on. Dang it. Oh, type in the actual like generic name. EDOXABAN.
Edoxaban.
does he think it's a roll?
Stupid
It
drug.
doesn't work though. We gotta change the venlafaxine. We gotta take away the venlafaxine.
Yeah. So either take it away or it's still.
Yeah, it's still
It just loves to.
increase risk of bleeding. Or we can keep it on there and let the doctor know. Like I would really monitor this patient really well.
Sure, closely. Okay.
Yeah.
That'll work.
So I'm gonna give you two options, doc. Either monitor this patient really well right now. What if you call this for the first time right when you got a pharmacy and you said it like that?
Yeah. Listen, doc.
Yeah, listen, doc. Yeah, so I'd either monitor the patient really well when he's taking this medication. Call him. I'd probably call him a day or two after, make sure that he's not having any symptoms of bleeding. And then as a first option, as a second option, we could look at his patient, his medication history. Maybe take away the venlafaxine because that's what's causing the increased risk of bleeding. Taking that with Xarelto. Or
Now you playing the role of a pharmacist and the doc? That's awesome.
No, y'all
Do you guys
y'all
do
can
the plug to the case now? All right, pharmacist, I'm here.
Oh, hi. So yeah.
I'm here. Here's my prescription.
Oh. Let me just check the interactions on that.
You don't even want to know my name.
Shut up. I'm busy.
I want to transfer. I want to transfer all these.
Please do.
Please do.
No, I'm just kidding.
There's gonna be days in pharmacy where you probably do have that altercation.
Yeah.
Just like,
Oh, yeah.
Please get
Hello, what's your name? Even though
John
you just
Smith.
handed it to me. Uh-huh.
And date of birth is 5/5/81.
Oh, cool. Awesome. So it looks like you wrote down on a piece of paper like a weirdo.
I did.
I have a
Scratch
counsel.
paper.
I have a counsel here.
Xarelto 20 I'll give you later. 20 milligram one tablet by mouth daily. 2
Yes.
refills. Okay.
Yes.
Well, looks here. My computer told me that interacts with venlafaxine to increase your risk of bleeding.
Wait, how do you know all that information?
I looked it up
Spying on
online.
Your computer talks to me.
Yes.
All right. Yes.
I'm spying on your profile.
Oh, okay. So that's okay.
Do you use any illicit drugs?
I don't think that's any of your business.
No one's gonna tell you that.
It is, because I want
I'm
some.
not required by law.
It is because invite. Yeah, I don't know how you asked about that.
What are you asking?
Do you smoke weed?
Hey guys.
You don't need to.
Hey, we can change the venlafaxine.
Oh, don't you have asthma?
To something else. Yeah. Or yeah.
Have you had any asthma attacks recently?
No, not recently. Not that I can remember. That's why I stopped taking my my Pro Air.
Ask him what he takes the venlafaxine for.
Yeah, what do you take your venlafaxine for?
You know what? I don't know. My doctor's the one who I don't remember. It was a long time ago.
Oh, it's for his social phobia.
Did he say anything about a DVT of the left leg?
Yeah, that's what he diagnosed me with. He gave me this prescription.
Okay, because you're supposed to be starting on 15 milligrams for that, but for the first 21 days. So do you know how long It's been since the DVT?
I mean, I just came back from the doctor's office.
Okay. I'll go ahead and give him a call, and I'll tell him that you have an interaction between your venlafaxine and what he just wrote, and also he probably wrote the wrong dose too.
Okay.
I think he's going to have to bring down that dose anyways to decrease the risk of bleeding. I don't really know what to do with venlafaxine now, so I'll ask him. Because I don't understand. I'm just a student. What, are you going to be the physician?
Yeah, sure. Go ahead.
Go over there and read your newspapers.
I'm gonna give me. Are you the pharmacist? Or no, you're the pharmacist.
I'm the pharmacist.
Call me real quick, man.
Ring ring.
Hey, this is Gene.
Oh, what's good, Gene?
Hey, what's good, Dr. B?
Hey man, I'm just calling. One of my patients has interaction between some drug you just wrote.
Yeah.
Venlafaxine and the Xarelto.
Okay.
Increases the risk of bleeding. Also, I looked up on micromedics and it said that he, I guess I'm not doing the S bar.
It's alright, you're fine.
You're good.
What's the patient's name and date of birth?
Oh, my bad.
It's alright.
It just says patient name, so I don't know.
That's
Say
fine.
John
Just
Smith.
make up
John
something.
Smith.
Make up something.
It's patient name.
Okay.
That's his name.
Alright, you said he's got a
They're
drug
very
interaction.
probable.
What do you think we should do about that?
Well, micromedics just says really you want to keep an eye on it and monitor the coagulation on this guy to see, like, look at his INR, his prothrombin time, all that stuff.
Yeah.
Just keep an eye on it. But it also said that for DVT, you want to start with 15 milligrams for the first 21 days.
Okay, I'm looking at his profile right now.
It looks like he wrote 20 though.
Oh, okay. All right. Yeah. Based on the literature, it says that you can do 20, the one that I had. So it's not that big of an increase. So I'm probably not going to change that right now.
How many days do you want this prescription to be for also? Because I noticed that's not on here.
Oh, okay. All right. Well, I'll correct that and I'll resend a new prescription with that information. Also, due to the interaction, do you think maybe we could try like Celexa or citalopram or something like that in replacement of venlafaxine? Can you check the drug? Can you check the
I don't know what those
drug
are.
interaction for me?
Sure.
Because I don't have my database for interaction up right now.
What are the doses? I mean the drugs?
Just do the citalopram. Citalopram and Xarelto.
No, same thing.
Same thing. All right, try how about
I think they're all gonna do that.
Well, this one doesn't. Let's try mirtazapine.
Asthma control is good. So you recommend Xarelto for.
Damn it, doc.
Does that one work either?
Maybe switch to venlafaxine.
Not only for the fasting, more for warfarin.
Oh wait. No interactions?
For mirtazapine?
Where's mirtazapine?
Mirtazapine, it's Remeron.
Is that an anticoagulant?
No, it's an antidepressant. Tricyclic, I think.
Okay, I don't see
Is there interaction?
Is that what venlafaxine is?
It's
Yeah.
Yeah, it's antidepressant.
Oh.
Yeah.
Depression.
it's for his social focus.
Okay, that would probably work.
Alright, perfect. I'll write a prescription for mirtazapine. You go ahead and check. And I'll make a note that you called me as well, and so I'll have that documentation for the patient.
I was just calling really to recommend though, if you want, since he can't afford that medicine, I'm just throwing something in there. Yeah, he can't afford the mirtazapine. His insurance doesn't cover it, so.
Oh, his insurance didn't cover mirtazapine? Alright, well, you
I'm just making that up. So
find a coupon.
I think since he's with all the other drugs out there, so for really the one that we want, we're gonna have that risk. So I think we might want to get the Xarelto down and then monitor him. So get it down to like 15, and we can monitor it from there.
Okay.
Kind of see where he's at.
I just I have my nurse record all my callings in case. So what I'll do is it might take about 30 minutes, but I'll get her to listen to this conversation, write down a new dose.
So try
mirtazapine, and Xarelto. If we decrease the dose down to, what was it, 15?
Yeah.
Alright, and so she'll listen to this medicate and we'll send over a new prescription in the next hour for this person.
Okay. Sounds good to
Sound
me.
good? Alright, good.
Oh boy.
See, that was a little longer than expected, but that's how it can be sometimes.
Yeah,
That's
exactly.
realistic because I mean I came with a
You
recommendation,
threw a
but
couple
it was
curveballs as far as like whether it falls or it's covered by his or her insurance.
So,
And then going through and looking at other drugs that can replace.
yeah, usually I would try like, maybe 2, at least for the time that you have, try at least 2 or 3 drugs. Try to think outside the box. Problem is for phobia, that also antidepressants are used for phobia. And so that's where obviously.
oh yeah, maybe suggest that he stop smoking weed because it's making him paranoid.
He's smoking I've seen his patient profile, he's smoking
A couple of joints
a week.
a week. Oh, that's not even a lot. It's not a lot at
It
all.
really is, but at the same time, how old is this guy?
He's 36.
Honestly, 36?
36,
He
35,
good. He
something
can
like
smoke more. Don't.
His asthma's
I just
fine.
would leave that out.
He said his weed helped his asthma.
This is doing a great job, yeah. All that coughing.
Yeah, I bet it's really good for about 5 minutes. I mean, yeah, you're
And
coughing
then
your
you
ass
need. Bless you.
off. That's pretty funny. I'm so hungry right now. I'm gonna go up there and eat my lunch.
Oh my god.
I just don't really
Got like 40 minutes.
know what recommendation to make. Like,
What?
I just don't really know what to recommend. I'm just
Oh,
like,
for this patient? I mean, you could mirtazapine might be an option because he said there is no drug interaction between that and the Xarelto, right?
are they the same class? The venlafaxine and the mirtazapine?
Yeah, they're antidepressant.
Okay, because I know
They
you
may
can't,
not be
you
the
can't
same
suddenly
class.
discontinue.
You have to taper.
You gotta taper. You gotta taper
can-
people off that stuff.
Oh,
Yeah.
oh, you have to taper it before you
Is
switch
it
it?
SSRI?
Is that what the guideline says?
Yeah, because any antidepressant, you have to taper.
That makes sense. That's what I was just thinking about. I was like, can we switch to that?
Oh, so he's been taking the venlafaxine,
Wait,
taking it
but
right.
if they're in the same class, why would you want to taper? You're not completely, you're just replacing one with another.
True.
Antidepressants are like ready in the morning. One will work, one won't. So it just depends.
Oh,
I mean, you can switch off those constantly.
We don't know what the dose is, like how that.
So we can say, I got 2 recommendations for you.
To minimize
One,
the risk of having episodes.
the thing is, this person, if they really need the warfarin, they need the warfarin over the antidepressant all day. And so I would say,
because that blood clot could like.
They need the Xarelto.
exactly. So I would say probably
But you can
either
lower
taper off the dose
you can lower the dose
of the warfarin.
anyway.
Oh, you're gonna lower the dose of the antidepressant. If you,
Yeah, because you're tapering it, so you're lowering the dose.
You just have to monitor.
okay, so you're saying if you switch to mirtazapine,
What would happen if you put him like? If you,
Oh, he
if
missed
you
his venlafaxine dose.
Lower the dose
Like once a month,
of the
maybe.
initial antidepressant, and then put like
So maybe say, hey, just keep an eye on
taking
it.
2
Set an alarm or something.
antidepressants at the same time.
oh, he misses it like once a month.
It's not a big deal.
Lower that and then.
No.
Yeah.
He's pretty much 90. He's like 29 out of 30. You know, he's
We
taking
haven't
it.
got to that yet.
Yeah.
I think you'd be a little bit safer to because they would have to come back within like a week
Oh yeah, to get their
to get a new taper.
new taper dose.
Oh,
So you're saying if
fast
you
food
switch
and
to
hot pockets.
mirtazapine, you'd lower the dose, even if you
Yeah, and
switched
as
it.
a taper, that
Also recommend that you get some exercise.
5 milligrams per day at intervals are low.
Even if that doesn't have an interaction with the warfarin, even if the mirtazapine doesn't react with the warfarin. I mean sorry, yeah.
Even though it does.
Yeah, the Xarelto. No, it doesn't. Mirtazapine doesn't have an interaction with Xarelto.
No, but since you're not taking them, I wouldn't take away the venlafaxine right away. You would taper
Okay.
that.
Okay.
But I would still give the Xarelto, but they have to come back in a week anyway to get a lower dose again.
Yeah.
So you have to really monitor just to make sure that they're not having any symptoms.
Okay. That's a good recommendation, I think. Yeah. Start tapering him off of his his antidepressant medication while giving the anticoagulant. That's a good recommendation. Glad that you said that. I didn't think about the tapering thing at all.
I didn't know. I thought that was only dealt with like steroids and like seizure medication.
Antidepressant, if they take it as long as a patient, take it for 6 months straight every single day, then that would make sense, I guess. I don't know how depressed somebody is.
Well, it's not used for he's using it for his phobia.
Yeah, that's true. He doesn't need it. Stay indoors for a couple weeks while you take this Xarelto.
But I mean, you just don't know you just don't know what his episode will be like. Whether he would harm himself, he could harm someone else. You don't know the extent of it. You try to minimize that.
All right. Any questions so far with this application? What is the hardest thing to do with this scenario?
Figure out what's going on.
What's difficult? Doctor's not available, is that what you said? Figuring it out. Okay. All right. Well, that's part of it, right? So using those clinical skills to figure out something.
What to do.
It's not just always going to be laid out as a paragraph for you and communicate this paragraph to someone. All right. So do what?
And also, when you figure something out, you're trying to decide if it's really a problem you need to call it.
Okay. So when you figure something out, what actually warrants a prescriber call versus maybe patient education? Right? So as you guys get more practice doing that, you'll figure out, okay, they're just not using their whatever correctly. Maybe just teach them. Or hey, this needs some action. I gotta call somebody. Okay. What else? What other things were difficult? What other things are unclear? All right. So let's go to. We only have time to do one more.
Doctor,
Oh yes.
can I ask what your recommendation would be in that scenario?
Which one?
For the Xarelto and the antidepressant.
Okay, so the problems with, off the top of my head, the Xarelto one was the wrong initiation dose, and we kind of did that one at the very beginning. But they were only starting the maintenance dose, so either maybe they started the initiation dose in the hospital, we don't know, right? So you can either clarify, hey, the patient already, have they already started using Xarelto? Are they on the titration dose? Or if they weren't started, then you need to let the prescriber know that given normal functions and that they need to start on that initiation dose of 15 milligrams twice a day for 21 weeks, and then they can start using the maintenance dose that was sent in to you. Some people asked about the Xarelto effects or interaction. That's really a non-issue at this point. For the Ventolin case, you've got a patient who maybe has additional triggers, but they're using their rescue inhaler very frequently, 5 times a day, and they're on a dose of their steroid that could potentially be increased. So maybe their dose just wasn't enough to control their symptoms, so you can potentially recommend step up in therapy for that, for their inhaled corticosteroid. So that's the main issue with that one. And then for the other case, I can't remember what the other case was. Okay, so then a side effect that the patient doesn't agree with, right? So maybe trying to see if they can change therapy based on unpalatable side effects. I don't know. Maybe the patient does worry about it. Some people could stand to lose some weight and they're okay with it. Some people it's concerning to them. So it just depends on how the patient feels. Are the side effects acceptable or are they unacceptable? If they're unacceptable and they don't want to continue with it, then you could potentially bring it up with their physician to see if the physician agrees. Now, the physician may say, hey, we want them to be on that anyways, but at least you've communicated that concern with their provider. Anything else to add, you guys? Nothing? Okay. All right, so let's see which one did from us. All right, so last one, go ahead and pull application 9. Oh, actually, we're not gonna write a note on this one. Go ahead and do this one last round. All right, so we can have more. I don't think we've given everyone feedback yet, so this gives other opportunity for us to give you guys more feedback, and then we'll end with questions. Okay, so pull app 9. Go ahead and do this.
I just feel done.
Thing is, oftentimes you notice that pharmacists, this is a major interaction, they've been taking.
Now, application 9 is a little bit easier because the assessment and plan is already there.
Anything else that
Okay.
hurts for your interaction is serious
And something not to be
overly cautious.
But everything.
Retail, you just don't have time for this. Darn it. No, you're Bill. I think I'll look that up.
Alright, doesn't look like my man's on a statin, so blood pressure. Just take the he's straight, he's straight.
Numbers for this. I'm looking for the numbers. LDRs.
What you need to do?
My man's not taking any blood pressure
Is
medicine.
it a woman?
You're taking patient 1, right?
He's not taking any blood. I'm on patient number 1. His blood pressure is really high right now. Like, not good. He's not
It's a
taking
girl.
any medication.
Or a woman. She's 74. She's a woman. She's all.
Okay.
It's kind of good, like having to take her notes.
She doesn't
Spanish line
believe in
2. That's what they do in my pharmacy. Spanish line 2. And they get somebody else to do it.
Really?
Every time.
Where do you work?
Really?
Where do you work?
No, I'm talking about at my rotation center.
Oh, rotation.
Yeah.
She's like, no, they just want me to pay them money. I couldn't see them every night.
It's good for you. You're supposed to take it.
Oh, you can't come inside.
You
I'm
can't
sure
do
about
that. That's tough.
Yeah, how is this person able to talk to you right now? We need to get them to the hospital.
They have 2 cups of coffee in the morning. When the hell did you have coffee, bro?
Dude, that's emergent, man. That's like borderline.
Isn't it?
It's like 80,
Isn't it?
80, what, 84?
Can you recommend that the blood pressure rate right now is actually at a silent killer maximum? Get them to the hospital.
She's not demonstrating any what is it, body injuries or whatever.
Hold on, let me look that up.
Is there 3 applications, guys, or is it just this one?
Hypertension?
Yeah, I don't know.
I'm gonna go back and look at the next one.
Because there are 3 different patients.
You know what, this is good though. Like, in my previous rotations, like, I've seen, like,
Oh, okay. There's basically 3 applications.
So, one of the 3. So just do
Let's do the first one, guys.
Okay.
they're like on 12 medication, and this is just
You're at an outpatient clinic.
they do like 12, 13.
Findings. Okay. So. So, like, my question is, when you're presenting this information to the physician or the provider, do you need to make note, like, oh, she has had, breast cancer and colon cancer, GERD, DVT, gout?
When you're talking about when you present it to the physician?
Yeah, so like for instance, you have your your situation, like, hey, this is a patient, blah blah blah, and then you go into like background.
For these type
I don't think so.
For these type of purposes?
Because you're looking
decades ago.
Okay, so you want to just address the high blood pressure.
I would address the high blood pressure, but for this type of situation, because we're at school, I would do those other
And
things.
you are conveying this note in SR format to the physician. So you're essentially doing
Yeah, I'll be. Yeah.
You want me to be patient?
No, you're the observer. you're yeah, I don't know. You can play a 74-year-old Hispanic female.
Comes like inflated because their blood pressure.
Okay, so
So you don't really know anything
Doctor-
technically, right?
yeah. So like I guess I'm just presenting to
I'll give myself JVT real quick.
Okay.
We'll
So
see
this
this
is a case of a 74-year-old Hispanic female who presents to our clinic.
I guess it's a choice.
She has had an extensive past medical history, which includes hypertension. Today she presents with a blood pressure of 184/64. I would recommend putting her on blood pressure medication because I don't see any that would any in her medical history. I would be concerned if she doesn't show any signs of emergent hypertension on our physical exam, and I was wondering maybe putting her on
We'll start in
like a-
hydrochlorothiazide.
Yeah.
It says right here.
Oh, that's the recommendation. Oh, she's already on? Oh. I didn't scroll up. Okay. I don't know.
You're the doctor this time.
Oh, okay.
Sorry, you're the pharmacist.
Hypertension. It doesn't stage it.
Yeah, it doesn't. But
It's stage. That's definitely stage 2.
two higher.
Yes,
Okay.
I talked to you.
Yeah. So my recommendation would be Losartan with hydrochlorothiazide, 12.5 milligrams. Our goal is to get to less than 150/90 per literature.
Just go, okay, for those patients, okay.
Alright, that sounds good. Thank you for calling me. Her blood pressure is very high. I want to see her, and I'll make a note for us to call her, try to get an appointment in the next couple of days to get her that medication. Also, I want to get her blood pressure medication, make sure she wasn't drinking coffee right before or anything like that.
I already have the.
And since it's gone up that high, I'll probably go ahead and make a note for one of my nurses to call her today and make sure she's alright. Experiencing symptoms.
Okay, please.
What else do you got for me today?
You said it's going to take some several.
Perfectly fit.
Okay, just move up the line. Let the next person.
I don't have any other issues. The major concern right now would be the elevated blood pressure.
Absolutely.
In her case, there are other morbidities that need to be addressed, but as of now, the emergent hypertension.
Okay. All right. Great. Well, like I said, I'll make a note for my nurse to give her a call and get her in the next couple of days. So we can get that medication to her and help control her blood pressure. Besides that, I know your recommendation was to try the Losartan. What do you think about adding ACTZ?
Yeah, that would be another option. Only because we are trying to, due to the fact that she is currently at 184, our goal is to get to less than 150. Would need 2 forms to get to at least get
she's
down.
at stage 2.
Stage 2.
Beyond. I mean, it's really high.
Right.
So I like that recommendation. I got a note of it right here, so I'll whenever I see her, I'll run the drug interactions as well, so we can get that
taken care of.
That way you don't have to call me back or anything.
Sure, understood.
So I really appreciate you calling me.
And when will her next appointment be with you?
I'm gonna schedule her for the next couple of days.
Okay.
Because her if it was a lot lower, it's too high right now for us not to go ahead and take care of this problem. So I'll probably say we'll get her on the schedule in the next couple of days, and I'll send you a fax with that information. Sound good?
All right, sounds good. Thank you very much for your time.
No problem.
Now you have to find one.
All right.
So it was good
Okay, no,
that, you know,
I was
we don't,
pretty
right now
sure,
you
so I
don't
was
have
trying
time
to tell
to
the,
go over drug interactions with her
doctor
blood pressure is high.
what
So I
Right.
like how you went
recommend
over, you
because,
said, you
that
know,
plan was
the
to
only thing that
reduce
is major
the goal,
concern was the hypertension.
reduce the blood
Gave the
pressure to
rate,
less than
I told you that I want to check her blood pressure as soon as she gets here. Make sure she wasn't drinking coffee, and make sure that it wasn't a false elevation.
Sure. I mean, and it's been steadily increasing. So this could be a progressive and not just a more chronic than acute.
So that'd be a good thing to also say probably on the phone
Yeah,
to the
so
doctor.
I described who the patient was and I told the doctor about the
I mean,
medication the patient was
her
taking.
LDL is,
But I was
I don't know if that's even
I
helping
didn't
with
know how
Yeah,
to
so you can do, you know, her blood pressure wasn't checked.
know what
While
course
it
medication
was
to
high
so that I can
the last time you
let
checked
the
it,
doctor
a
know
year and a
that.
half ago.
I would say also you want to look at their LDL. How to get my LDL go, yeah.
Yeah.
I'm on a statin.
So we could, as far as the follow up, we can say like treatment for the hypertension and then follow up with
So it's just like
her cause because she has a
But you also ask them, ask the doctor, go ahead and check her granny plans, make sure it's medication.
oh yeah.
I don't know for sure, to be completely honest with you, as far as I know, checking like ACEs and ARBs, there really wasn't, it seemed like there wasn't a whole lot of dose adjustments with the main ones that are used, as far as I remember. But I would still maybe go ahead and, if you have time, mention it, and if you're craving
all
for it,
that,
sure you need to
maybe
reduce
their
your
vitals
doses or
is
anything
because
like
it's
that.
blood pressure related, okay? All that stuff.
But
Then, based
So
on that
just
information,
HDLs
your
are
assessment
right?
should
HDLs,
A
yeah.
little bit low.
Yeah.
Because
But I mean,
if it's below 50,
yeah, then it'd be concerning.
So the LDL for
The
her
LDLs
age, I
are-
think
top
is
to bottom
okay.
what's going on
It's
with
not.
the
It's a little bit
patient,
right.
So
Yeah.
you got to
Anything
present
what
that
above
information
90
so
is
that
like
it builds your case
kind of getting up there.
for your assessment.
Yeah,
But most
because
people with
You don't
LDLs
present
have like
every single
170,
thing.
180.
You need to
Primary
determine what is
concern is the
what is related to
hypertension.
your
Secondary, if you have time, go over the
go over the LDL or cholesterol.
And so what, since you're not taking a statin right now, go ahead and, I'd go ahead and also check her cholesterol levels, get a fasting lipid panel, and when I
Does
call
she-
her to schedule the appointment, I'll tell her not to eat before.
Also give immunizations.
So you
It says
can focus
none.
No, there we go. Also, when she comes back by, I'll
Yeah,
offer
so
her
you
a
have
flu
other,
shot,
other things
Dr.
too. You can have multiple.
You
Dr.
just say
O'Neill.
we're gonna go ahead and give the flu shot today.
But you don't want that to
You know.
be, or like,
So she would
But there's
yeah,
sometimes
she's
there are
old.
problems.
So how many risk factors? So she's not a
You know,
smoker.
after you've done that,
We don't know her
and
diet.
also,
DVT.
We don't know her weight.
Dang, they've had a DVT before.
Yeah. There's a lot of things.
Does it say that?
Yeah.
So,
That is called
so literally,
DVT.
grandma's in here like.
Yeah. Burn, gout.
I'm blood feels like it's not really running through my veins correctly.
you guys calculate the ASCVD
They
risk.
can't tell
depends on what the
that.
risk is. Depends on what
They
the
can't
risk
tell you that.
Let's see what the risk
pattern
is.
and they can say, I got two issues.
What was the total cholesterol?
I got 2 issues.
208.
Where's their age?
She's 74.
Or whatever.
okay,
She's not a smoker.
okay.
Female, other.
Do you need her
Your Dr.
HDL?
her what?
HDL is 50.
HDL
Was 54.
yes, 54.
CVS pharmacy.
LDL was what?
I have a patient of
LDL.
115. Her name is NK. She's a 74-year-old
And systolic
Hispanic lady.
was 180.
And,
184.
she's
184,
been,
yeah.
we've been treating her.
History of diabetes.
Anything above 160 stays
No.
And recently, she
On
was diagnosed
hypertension
with,
treatment.
She has
No.
type 2 diabetes, actually.
That's
Oh, she does?
that's a family.
Are we- was it family? I'm sorry.
On a statin, no. On
that
aspirin,
that she's being
no.
overwhelmed with the other medications she's taking.
24.
Based on
Yep. 24.
Yep.
profile of what we have currently,
That's her.
ASCVD risk?
Yeah.
10-year risk is what, 74?
27.
Oh, 27?
27%.
Alright, yeah. And I'm also going to have my nurse talk to her, ask her if she's having any shortness of breath, anything like that, chest pain.
Also,
Because with thrombosis,
Moderate to high intensity statin.
Oh.
They're in this group right here.
moderate to high intensity.
So that's what I'm saying.
74?
Because she, like, you've been told her, okay, let's start.
So you put her on a moderate
today.
statin. Bless you.
Alright.
No, a high because she's under 75.
Lady.
So you put her a high statin.
Spanish line too.
We are overwhelming her.
Oh yeah, up here.
Medication.
Yeah.
She
Whoa.
is currently
Wow.
diagnosed with hypertension
You put her on
and
a
she
high.
has
Cool picture.
treatment for cancer and some other
Yeah, definitely.
such as gout,
Silver satin.
Rosuvastatin 40, 20. Oh, 40?
I'm gonna go 40. I'm crazy. Because that's the. Yeah.
I say Rosuvastatin 80.
Monitor her possibility.
What about my
It's a lot
myopathy?
cheaper.
True.
Levothyroxine, microzed for our permanent UTI.
Oh boy.
I just want to be done with this week. I just want to be done with
Bed
this
at
week.
9:30.
I'm gonna do. Not 30? What's about at 3 in the morning? I woke up at 7.
I can't do
How can you, what do you do till then? Is there studying?
No, I don't do shit when I get home at 5 until like I started doing homework at like 11. Maybe.
He usually does his girlfriend's homework and then his you don't do shit. You're just kidding.
Yeah, I listen to her
He
crap.
helps her, right?
She's distracting, man. She'll be like, oh my gosh, I got this interview with this hospital. Can you practice interviewing with me? I'm like, okay. I guess I won't study.
Boyfriend of the year.
Yeah. That ain't me. I gave up.
That's not me.
Okay, yeah. Return to the clinic in 2 weeks.
I started waking up at 4.
That's no?
Sneeze / cough.
I don't know, man. It's just a dry throat. I'm not coughing it up.
When you go over like allergies with somebody, any sneezing, coughing,
Oh, you Bryce, are you still tutoring for cardio? Like for, so can you explain the PAD? His lecture. Because all we did was a soap note and that was it.
I think that was the class where I was like, where he was telling everyone, yeah, you have a.
Yeah, he said. Remember he said it was a PowerPoint. No, it was a PowerPoint because the previous day he split with Dr. Sharpton for the emergency and urgency hypertensive, and then it came back the following day was PAD. And after PAD was there was something else.
Hey, I'm studying Monday afternoon and Tuesday afternoon all day. If you wanna, I'll be here.
You'll be here.
That was
Yeah,
last week.
so Friday, Saturday, Sunday will be dedicated for IPI. I just need to get all the my group project, my presentation, and
Oh, I know what you're talking about, where he threw that really crazy case at us with the EKG and stuff.
Yep.
I didn't get that case. I didn't know what was going on.
He posted, yeah, it was this one, right? And then he had like all these, yeah, and then that was it. We were done.
I didn't really know what to do.
I'm gonna talk to him today. Because I just want to make sure.
Wait, I don't remember looking at his PowerPoint.
Like in this situation. Today I went to one of the apartments because I can.
Yeah.
Then tomorrow.
She comes in your outpatient clinic. You get all the information and then you go talk to the doctor. Yeah, do you remember that? I don't understand, like, is that, he never explained it, he never talked about the pathophysiology of it, what drugs, what the treatment for it.
No, he didn't.
I didn't hear you. What is the the doctor, right? Asked that question, right? I don't know who asked it.
So one this morning, because they go Friday, and I was performance on Saturday.
I guess because there's communicating with the forms with the doctor.
Yeah, what? There's no answer on here.
There's absolutely nothing.
Have all the information.
I was looking at it and I'm thinking to myself, I'm like,
What is a pre-existing condition?
so the way we approached it is, you know, she has all these things wrong with her, right? But she presents with that blood pressure 184. That's like your main concern. Because you can go into, oh, she has osteoarthritis.
I understand that, but like, do you answer her question?
So you would he would let the doctor know this is the plan. Like, you know, she comes in, she's not on any blood pressure medication. So you've already stated like what she is, what she has, but the most important thing is her blood pressure, which is
And then
concerning.
second, is there dyslipidemia?
Yeah, that would be your second, but your first would be, because if you look at her medication list, she has no medication for the treatment. It's been steadily increasing for the last couple times. So you would convey that information, and then you'd make your recommendation. Hey, if you scroll all the way down and say that I'm put on Crestin or anti-hydrochlorothiazide as your option, what do you think of this stress? But yeah, I need to go talk to him, because that whole lecture was not even a lecture. That
It
was
wasn't.
just like,
Neither was his last lecture.
it was a lecture. I had to go on YouTube to understand that.
Oh yeah,
You
that
know,
was
the STEMI
yeah.
and the what is it, the SCS? Oh, ACS.
Acute coronary syndrome.
Yeah.
The last email that she sent.
I don't know
I
what that is.
found more of an understanding than what he lectures. So
Oh, they're understanding.
what?
Yeah, she did. I don't think I have a I didn't. But you remember the last one that like just last week? Like maybe it has like the dates for the next week.
Like, you know, I think it's gonna be a lot easier
There's a quiz I was gonna
because
take. I saw the email.
it's tough. I mean, the reading is even for his lab,
I just
no one had a perfect score. Because remember last year, no one had a perfect score. So I'm like, how can you not get a perfect score?
Are you talking about the quizzes that had the answers? Yes, I put them word for word in there, and the ones that he told us to change with the R to R question. That was the only one that he changed. I was wondering the same thing. I was like, because I got an 80 on one of them, and I was like, why? It doesn't make any sense.
Yeah, that's.
They're making it seem like it's minimal grading, but I'm like, well, 6% is a lot.
And then some people are getting 30s.
It makes a difference. It drops you. You can drop you 4 or 5 points.
Yeah.
Yeah.
It makes a difference because when you're right now, because the school number, you yourself have an A, but then
Yeah, I was like, I wonder if that was
whack
whack
where your teammates shouldn't hurt you.
Yeah, it's supposed to help. I think we can just say, I don't want my team hurt. Just give me my own grade.
Okay, let's wrap things up.
I think also
So,
that last lecture he
any-
had, he needs to
I guess
clarify
what
what we need
questions
to
for this particular
the
application you
exam
have?
will come back.
What doesn't make sense? Well, it's difficult. Or pretty much the same as the other ones. No comments or questions? Okay. So, I'll assume you guys are experts already. Alright. I will add one comment just because of what I observed, even though no one's willing to fess up. So, when you have something like this, when you have a lot of information, all right, what you need to think about is, what do I need to present to whoever I'm talking to? And I like to think of it as building a case. So, by the time you get to your assessment and plan, everything you said before that has to make sense to the listener. So as you're presenting, subjective and objective information or situation and background, the person listening is also, in their mind, working up the patient just like you did, okay? So by the time you get to assessment, your assessment has to match whatever you presented. And likewise, the physician or whoever is also going to be trying to think, okay, yeah, this assessment makes sense based off of the information you provided. Now, they may ask for some more information, and that's fine, but the assessment has to match the information provided. And likewise, when you get to your plan, that has to match with the assessment. Does that make sense? So every time you present something, you're building a case for the next component so that whoever's listening can either agree or they may disagree. They may say, oh, well, based off of what you said, I actually think that this might be going on instead. And that's perfectly fair, right? But either way, you've got to present it so that it makes sense to the listener. Okay? So it takes a lot of practice. try writing this stuff out, or try, in your mind before you talk to someone, planning that out beforehand. And I mean, I had to do that too. I mean, I wasn't an expert on it when I was a student. It took a lot of mental preparation each time I had to call a doctor or talk to a doctor or the nurse or the medical resident face to face. And that's okay. Some of you guys might be natural pros, some of our faculty may be natural pros. For me, it took a while. I had to practice a lot. So don't just go off the cuff and just do stuff and make yourself look bad, or you really want to get that 90% or greater prescriber acceptance rate for your recommendations, and that'll help if you are organized and it makes sense. Okay, so feedback for the class. What did you dislike about the class? What things did not go well or didn't help your learning? Okay. Gotcha. Okay, so some of the clinical stuff you haven't had yet. Okay. What else? That'll be my challenge next year when I teach P1 to would have had 0 therapeutics at that point. So, yeah, I need to figure out how to do that. So, all right. So what else besides not having the therapeutics yet? Anything else didn't go well? All right. So what did go well? What did you like? What was helpful for you?
Like leaving the voicemail, talking on the phone.
You like those? Okay.
Yeah.
Very interactive. Anything else? Okay, any final questions, comments, concerns? Professors, any final comments, questions, or concerns you want to convey to the class?
One last thought about voicemail. It takes a good 5 seconds that it takes to run through in your head what you're going to say before you call, and kind of have your voicemail planned in your head just in case you do get voicemail. And that way you don't have to come up with it on the spot. That's just a tip for the day. Okay.
Planning is good.
Just being concise and confident would be my advice. You want to sound confident, not unsure of yourself. I feel like I give that feedback. If you sound like you're questioning your own recommendation, they're not really going to take it. And just being concise, like you had mentioned, build your case. I heard a lot of people saying just basically reading a lot of information that wasn't really pertinent to the issue at hand or the recommendation. So just provide enough information to support your recommendation and to support your assessment of the problem or the issue at hand. All that extra stuff is just fluff. They're not gonna care about their headaches and they take Tylenol PRN if you're talking about some issue with their breathing.
All right. Thanks. Dismissed.
Yeah. So are you going to talk to him or?
I don't ever talk to